So now I'd like to welcome you to today's webinar, Patient Misidentification, a Wicked Problem, the paradox between improving patient care and the adoption of technology, sponsored by HP. Our speakers today are Sherry Hess, Chief Nursing Informatics Officer at Banner Health, Ricky Jennings, Chief Nursing Informatics Officer at Zebra Technologies, and Daniel Colling, Global Head, Healthcare Industry Solutions and Practice at HP. So with that, I'll hand things over to Daniel to begin the presentation.
Well, thank you very much for having us today, Bridget, and talking about this really critical component surrounding patient identification and in clinical settings. A huge thank you for Sherry Hess for joining me and Ricky Jennings as well. So initially, what we wanted to just look at is patient identification. It's still being a global healthcare challenge, and clearly with nurses, we are at the front line of healthcare delivery in all settings, and what that means, unfortunately, is most likely we would be the witness, or we could be involved ourselves in clinical practice error because of misidentification, and I would imagine all of us on this call as nurses, that would occur sometime over our career. So, showing my age a little, the term never event really was coined and came about in the early 2000s. And this really described errors that should never occur in healthcare. However, uses of this term have extended to include serious, preventable, and really identifiable adverse events. The never event list, as we look at it now, has grown to over 29 serious reportable events that are grouped into 7 categories. These include surgical or procedural events. It could be also the category of product and device events. The other category is patient protection events. The fourth is care management events. And then remaining, we have environmental events, radiological events, and criminal events. As examples, never events include surgery or invasive procedures that are conducted on the wrong patient. And as we see in the care management category, as an example, medication administration errors would be involving the wrong drug or the wrong patient, or procedural errors. So looking at patient misidentification, as it is categorized as a never event under care management, all nurses, we have experienced this, potentially one of our colleagues and has experienced this. And this, as we know, can result in catastrophic outcomes. Because the reality is that patients could die because they are wrongly identified. In a very interesting study, this is in the European Union, that it's surveyed a little over 770 registered nurses. There were 73% that described the potential for patient misidentification was rare and an unlikely event. And with only in that study, there were 9.1% of nurses admitted that there were some problems associated with patients being misidentified over multiple hospitals and health systems. So it would seem, based on this type of a study, that patient misidentification not be as much of a problem as we think. However, there are many studies and statistics that suggest otherwise. This is a recent annual report from SHOT, which is the Serious Hazards of Transfusion Steering Group. And this came out of their annual recent report. And one of the critical findings that they discovered that over 85% of the 2,000 760 reported near miss incidents occurred due to care provider error. And over 75% of those errors occurred in clinical areas as opposed to the labs. Another study has indicated that 14% of medical records include patient information that is tied to the incorrect patient chart. So with even a national focus looking towards the U.S., patient identification errors, they still play a significant role in contributing to PAEs, or what we refer to as preventable adverse events. And as such, since 2014, the U.S. Joint Commission still holds that improving patient ID accuracy is really the most important for national patient safety goals. So with that in mind, with an increased national effort, and there's significant investment in multiple different types of technologies, I think a lot of us still ask, well, why does patient misidentification still occur? And there's multiple factors why that occurs, but one that often we forget or we fail to look at is when it comes to the adoption of technology. So, we're all on this journey of adopting an EMR. Sherry Hess being at Banner Health, they achieved HIMSS stage 7 or EMR MRAM adoption stage 7 quite some time ago, and other health systems might be stage 3 or stage 4. And one of the outcomes of the EMRs we were hoping to achieve was having all of the right information at the right point of time, at the right point in the workflow for that clinical workflow to provide a clinical decision support. And what we saw was, as an example, many health systems that adopted an EMR, it actually reduced productivity. We moved to a very metric-driven, compliant-driven system, and it took nurses from being face-to-face with patients and burdened us with a lot of administrative tasks that we didn't have to do before, as well as significant check boxes that we had to complete in the EMR. And so one study I bring up just really briefly is, for the first time in history, this was conducted in 2018 by the American Physicians Association. A little over 50% of physicians are not recommending medicine as a career to their children. And an additional study is fewer nurses are entering the workforce. So you have this paradox of adopting technology, with the American Affordable Act, having patients have more access to care, which is wonderful, but being burdened down with technology or software that really was not truly built side by side with clinicians. So with that in mind, Ricky is now going to talk about positive patient identification and give some examples of that.
Thanks so much, Daniel. Positive patient identification is clearly vital throughout the patient's entire journey. We often say from patient admission to discharge and every step in between. There are, however, many critical points in this journey where patient identification is necessary and can be jeopardized. Workflows such as medication administration, patient transfer and handoff, procedure initiation, and specimen collection solely name a few. Thankfully, there are several strategies in place today that all work to minimize the likelihood of this patient identification error that Daniel introduced us to some trends in the previous slide. These strategies include every patient being assigned a unique identifier that is truly unambiguous. Every procedure, treatment, or medication workflow begin with positive patient identification as the first step, as well as patient identification being maintained throughout the patient stay. So when I say that, most specifically, as when a solution's being implemented, it is critical that we identify and resolve any opportunities for workarounds to maintaining this positive patient ID system that's in place, and most specifically, that's often relates to wristband, and we'll talk a bit about that a bit later. Over 13 years ago, actually, the World Health Organization recommended that healthcare settings consider feasible implementation of technology systems to decrease identification errors. Yet, this area is still in need of investment. Application of a patient wristband at admission is widely adopted today to mitigate the likelihood of this error. These wristbands display the patient name, date of birth, medical record number, and barcodes for scanning for different administration processes down the line. However, even with patient wristbanding, it can still be problematic. A recent study actually revealed that 1 in 10 cases of patients being mismatched to their care were directly related to the wristband. These problems range across many disciplines. However, they're becoming increasingly present in patients that are high risk, often with skin sensitivity issues, or more specifically in neonatal care settings, such as the NICU or even in labor and delivery. Now, I'd like to loop in Sherry to share some examples with us. So, Sherry, even with wristbands being a standard in practice for patient identification, what are some of the problems you've seen with patient identification?
Thanks, Ricky, and great question. So having spent the last 35 years plus in healthcare, I've seen many pitfalls at whether I, as the nurse at the bedside, in the NICU, or in healthcare IT and delivering technology. But I really think about at this point in my career, how do we take that human failure out and make identification as easy as possible? Imagine you're that new grad nurse who just started during this pandemic. You didn't get to spend your last semester of clinicals on the floor, and now you're working a very busy floor with contract nurses, and probably the unit you're on has been converted from, say you're in the PACU now, taking care of med-surg patients. And maybe you were only shown once or twice how you would place that armband on your patient. And during that process, so now your patient either doesn't have one or you're going to initiate that, and you're trying to remember on top of all the other things that are going through your head and the 5 or 6 other patients you may have. So you're going to get that armband, put that on the patient. During that process, you're interrupted multiple times, and then ultimately you place that armband on the wrong patient. Think about those downstream effects and what can happen when you do place that. As Ricky mentioned, we know we give medications around that, some labs being drawn, or maybe giving blood, procedures. Nurses are being asked to do so much more with less. They're tired. Some of our nurses have already lived through some of the early COVID. We're seeing some PTSD with them. Our Arizona nurses are still in the thick of caring for more patients and being full. But that new grad nurse, at that example, they could be scarred from their move forward. And even as you heard Daniel say, are there as many nurses? Are we going to have as many nurses as we need? We have to be sure that during the processes and as we roll out technology, that we aren't giving our nurses that opportunity to create those workarounds. And it's not because they don't want to follow the process. It's that process has become so complex and it may slow them down. And if any step fails, like I go in to give that medication, the armband is not scanning, and maybe that happens on a regular basis, well, what am I going to do? Well, I may then print an extra armband, carry that around, or, a patient label that is there for a backup. Now, luckily, we've learned many of those workarounds over the years, and we don't want patient labels and armbands to have that same barcode on it so they can't scan that. But I think the other piece is if your patient is coherent, always be sure that we are asking them their name. while they're scanning it, explaining to the patients when they first arrive that we want them to be safe, and that we do that by scanning and by also confirming that that's their name and birth date, and to empower them. So I think there's a lot that we can do, but the first thing that comes to mind for me is really taking that human failure out and trying to decrease some of those errors. You know, our nursing director is also being held accountable to decrease overtime, which means that, you know, nurses are scrutinized even more, trying to juggle so much of what they're doing and get it completed in a 12-hour period. So as you're hearing, you know, maybe that sounded a bit, it seems so simple, put an armband on a patient, and actually the steps that need to occur are very complex, because you don't even know, can that nurse, do they have the ability from a technology perspective to print that, or does that only come from registration? There's many pieces around that, but we have to be sure that if there's inefficiencies with technology, that not only delays addressing patient safety issues, it increases the risk and causes stress for our users and increases the risk for our workforce. So thank you for that question, Ricky.
Wow, Sherry, what a powerful example of today's environment. Really, it has given me pause, and just to think that there's so much to consider as we find ways to support our clinicians, in particularly right now. To reinforce some of those examples here, that's exactly what we're to talk about, is the challenges as it relates to wristband printing. You've heard it from Daniel, you've heard it from Sherry, and even as you read the title of this, you may think it's patient wristbanding. It seems simplistic, and as we've shared, there are a number of stop kits that can make it more complicated. Just as with any new solution adoption, particularly as it relates to technology, seamless integration into the care environment is absolutely critical to ensure that our clinicians, as Sherry shared, adhere to protocol and reduce the likelihood of workarounds. In the case of wristbands, in particular, the ease of use and comfort to the patient are absolutely essential. When even what could seemingly be a small disruption or break in the workflow could lead to a workaround with a negative outcome. Now, it's important to remember, just as we've all said, no clinician goes into his or her day with the intention to make an error. And so we as technologists, it is our role to help mitigate the likelihood of this happening. Simply in an effort to complete a task in the moment that could lead to a workaround, this clinician may make an error solely to increase patient trust or satisfaction, to do something faster immediately in that need. For instance, if there's a printer failure, this could lead to a manual process or irritation with patients who are waiting to be admitted. It was shared earlier, a smudged barcode, whether that's from exposure to cleaning agents or simple soap and water in a bath that won't scan, may enable a clinician to just elect to override scanning that scanning the medication or scanning that barcode just to deliver the medication on time. When patients become irritated by the wristband, they could ask that clinician to either place it on the bedside table or place it on the bed. I've even heard of having it placed on the wall in the patient's room. You can think of it, all of these open opportunities for identification errors. We have a saying that positive identification starts at the wrist. And when there's a hiccup or there's a break in that process, right there at that point on the patient's wrist, the downstream effects can seemingly multiply. Wristbands that can be easily printed or applied, you sure they're well-fitting based on the population you're serving, so whether that's the size or their softness, as well as wristbands that can withstand that repeated exposure to water or to cleaning agents. Another thing to keep top of mind, particularly in today's environment, ensure the continuity in the workflows and in turn create less disruption for our staff. I'm going to turn it back over to Daniel so he can speak a bit about Zebra and HP's partnership.
Well, thank you so much, Sherry and Ricky. So, Sherry spoke about some really great examples of, grads coming right out of nursing school and many of the challenges that they're experiencing. but looking at the whole picture, you know, we've made some great improvements to positive patient identification. First and foremost, by recognizing the importance, and what Sherry mentioned earlier is making us accountable. So the directors of nursing be accountable, but also the nurses not only being accountable, but something to think about as well is relating to the families that are with the patients or the patients themselves, the importance of patient identification and why applying a wristband in the proper methodology like Ricky described will really help and prevent any errors that can occur later downstream. There's been lots of technology that's been implemented and developed. It's pretty standard now for the US to utilize QR code technology or barcode technology that's been around for quite some time. We are starting to see in more developed countries the adoption of RFID technology. So that's radio frequency identification technology. And what that provides is the ability now to have the location of the patient themselves. And there's a lot of work being done with correlating that clinical workflow to tie where the patient is during their continuum of care, or potentially the medications that need to be administered, tying that RFID location services to where the patient is. And then lastly, Sherry mentioned blood products as an example, that being able to potentially be utilized so that you get the correct medication, the correct blood product at the right point in the workflow. Some other examples could include, we've seen some smartphone facial recognition technology. But with HP and Zebra, we've been able to have an exclusive partnership to look at, you know, providing purpose-built technology with the clinician in mind and really better manage that identification process. It's been 2 years now, but HP and Zebra, we've partnered through an exclusive managed global print services partnership. And some of these examples of solutions that we're showing in this image is utilizing, as an example, page-wide Zebra technology that could be utilized at the point of care with the triage nurse. Page-wide technology, what it does is it's not toner-based, so it has a reduced amount of airborne particulates. So that's really important for areas where patients are very sensitive. And then the media that it's printed on is really critical, like Ricky was mentioning earlier, so that it's comfortable fitting, it's not going to absorb and harbor bacteria. The technology that the printer is in that specific environment, especially now we're looking at COVID-19, is it has to be able to withstand the aseptic rigors. Clearly, you know, Sherry would probably attest to this, and everyone on this call is, you know, infection prevention policies and a number of times that surfaces, including IT surfaces, so displays, printers, mice, keyboards, are being disinfected, have increased exponentially. And so devices that are not built for those environments, they are going to degrade the plastic. So that's another thing to keep in mind is the device itself in association with the media being utilized can be able to provide a really meaningful experience, reduce or eliminate that human error like Sherry mentioned earlier, and be able to have in mind that when you're putting these solutions into place, you work hand in hand with the clinicians so that you're not increasing administrative tasks or burdening a clinician with technology, but you're making it very easy and matches the clinician's workflows. So Ricky is going to talk about specifically the point of care, patient identification, and provide some really good examples there.
Thanks again, Daniel. So we've shared earlier, we've shared it a few times, on how today's clinicians are working in a fast pace. Cognitive overload is a term we hear frequently used, that it relates to the amount of data, information, alarms, notifications that our clinicians are needing to field through as they provide care to patients. With that, disruptions are certainly present in today's environment and can lead to those inadvertent mix-ups in the human factors we've talked about, even keeping in mind Sherry's example about a new graduate nurse working in our current pandemic environment. As a clinician, I think we can all very much so empathize with that situation. Now, in a retrospective study for the wrong site surgeries performed in California over the past decade, it was discovered that the most common error was operating on the wrong side of the patient's body. And 22% of the wrong surgeries were the result of human factors, predominantly from medical staff, from medical staff who were peer-reviewed, reported fatigue, distraction, and even rushing. Now, there was another study that indicated 56% of identification errors were caused by incorrect specimen labeling, suggesting that those identification errors are more common than we previously thought in laboratory medicine. We've talked about the perception versus the reality and the data behind that. Also, in a broad study that evaluated 69 hospitals, found that although there has been a lot of development in the analytical phase of testing in pathology labs, more errors occur than should be due to human factors, either filing the requisition form or receiving and preparing the samples for analysis, with 3% of those cases having been identified correctly to the wrong patient. Much of our conversation today has been centered around the wristband's critical role in preventing patient identification errors. As seen here, proper specimen labeling is another critical juncture where errors can cause a significant patient impact. Errors in specimen collection could be as simple as the collecting clinicians perhaps forgetting to mark the date, the time, and the collector's name on the sample, or using the wrong tube for a blood draw before sending it down to the lab. An error that's more higher risk could be adhering the wrong patient's label to a specimen, leading to an incorrect result, which could lead to the wrong treatment. These errors can occur for a number of reasons. However, printing labels away from the bedside, that might mean to some batch printing of labels, or printing the patient labels at a centralized nursing station after collection, can largely contribute to these problems. Lab turnaround times are vital to timely care delivery. Lab results are certainly essential to proper diagnosis and the treatment response, and all are directly related to patient throughput. At this point, I'm going to turn it back to Daniel and Sherry to contribute some thoughts.
Thank you very much, Ricky, for the studies that really demonstrate the data behind the misperception or the misconception of patient identification. I think it'd be great for you, Sherry, if you could provide potentially an impactful example of patient misidentification, and what are some of the risks or errors that you saw, why that occurred, whether it was from a nurse or a phlebotomist.
Great, thanks for that, Daniel. The ones that really give me the most, I could say heartburn, is when I hear about those that happen during a surgical process, and Ricky alluded to this a bit. So think about that surgical process where the patient is brought into the operating room, and is their band on their arm, is it on a leg, but they're now draped under a sterile field, and you can't access that arm. So do you cut that band off at the time when, depending on where it's draped and where the surgery is going to be, and then place it on a patient clipboard, or is your process dependent, as I said, upon that surgery? The key is variability can lead to errors. So, is it removed prior to, or is there an extra one that is on the clipboard, I said? What's that standard process of banding during surgery? Because now think about to surgery is there's a biopsy that's going to be required. Well, Ricky also alluded to this a bit. Is a label printed before? Now, depending upon your electronic health record and your process, I've seen both over the past multiple years. So many times you don't want to have just a generic label. You really want that label to be a lab label that has the information on it, as Ricky was saying, so the nurse or whoever's labeling that doesn't have to put their initials or their identifier, a date and time, where it was drawn for. That is in the order. So if you think about the process and one that can be created, how complex that could be. So I, as the nurse, say circulating nurse, the surgeon is saying, I need, X biopsy, I want to be done. So I'm entering that, printing the labels in the room, real time, and then also labeling them, ensuring they're coming from the right place. So as you think about that, and many of you, unless you've been in that situation, don't even realize how complex that can be. So now think about, that worst case scenario, the specimen, let's say it was that generic label, and it wasn't even that patient's label. I've seen or heard over the years of labels that were left in ORs from previous surgeries. And so now I've labeled that specimen with Mrs. Smith when it was really Mrs. Jones. So what does that mean? The patient now may have to come back to surgery to either get a repeat biopsy or even a worst case scenario that it's been removed, they can't get another sample. And so think if you were that patient on that end. While they may seem like these should never occur, totally agree. You're seeing that, human factors is a piece of that. There's a lot of incorrect specimen labeling. None of us go to work thinking we're going to make that error. And our goal is that this never happens. So, but if you were scanning, so let's use the example of now I am scanning that label, that patient identifier also, you'll be notified prior to that lab leaving the OR and ultimately ensuring that the error never occurs. I think back over the years that I've been a nurse, and I made an error from an identification on blood sugar, and what I did was, as opposed to, now I didn't have a scanning at that time. This was probably about 7 or 8 years ago, and didn't have a scanner, but I had to type in the patient's medical record number. Well, I had my piece of paper, or as nurses we call it, our brain, of the couple of babies I was taking care of, and I typed in the wrong baby's medical record number. And this was a small 8-bed level 2 nursery that I worked at, and there was a nurse practitioner, and at that time there wasn't an order for the other baby, and the lab did call and say we didn't have an order on that. Now, there wasn't a bad outcome, but think about what could have happened. And think about that case where this has happened in the past, where I'm drawing that blood and I don't get that correct, and I'm doing a type and cross match, which we do prior to doing a blood transfusion. Now that patient goes to the OR, they have blood on standby, and the patient's given the wrong blood transfusion. That's the ultimate thing that we don't want to have happen, but those have happened before, and those are the ones that will stick with you for a long time when you hear of those errors that are occurring. Thank you for that, Daniel.
You bet, Sherry. Yeah, I can think of, because all of us have been in nursing for quite some time, so, looking back over 20 years, where there was a 2-year-old patient. This was a little over 10 years ago, but there was a 2-year-old patient who presented to the ED that underwent surgery, was recovering in PACU, so that's the post-anesthesia care unit, and was admitted to the pediatric unit later in the day. And then the next day, the night shift, the RN discovered the child had another patient's ID band on her wrist. And that ID band belonged to an 8-month-old baby who also had been seen in the ED the previous day, but had been discharged home later that day. So these are, these are anecdotes that happen and they're real, but the data still suggests that, by trying to reduce or eliminate human factors is really one of the keys to success for increasing and having positive patient identification and never having one of those never incidents or never events that we've spoken about earlier. Another example, as we see definitely in Arizona, I think you could relate to this, Sherry, is many people have the last name that is exactly the same in the first name, being a large Latino population. So you'll have Mario Garcia, and maybe their middle initial is changed. So it's really critical to not just have the technology be able to remove those barriers, but also follow through with the protocols of your name, confirming the date of birth, right? Confirming any other identifications that you're supposed to through your EHR and documenting that correctly, and clearly face-to-face with the patient getting that acknowledgement. Sometimes we're not fortunate, right? And there might be a patient that comes in and they are unconscious, but we still need to follow with the protocol so that we can eliminate any of these errors. So Ricky is going to now speak about specimen labeling that we just spoke about earlier, and really being able to automate that process so that you can remove these human errors that could potentially occur.
Yes, Dylan, exactly. We've talked about technology and automation being influential here in opportunity and reducing errors that could be related to human factor. Point of care printing in particular is increasingly being adopted to mitigate specimen collection errors. Equipping our clinicians with tools today such as mobile computers or a smartphone, as well as a mobile printer, enables the clinician to do specimen collection and have it completed from start to finish without any disruption directly at the patient's bedside. This means that a clinician can scan the patient's wristband, validate that the correct lab work is ordered for the correct patient, select the appropriate test tubes, draw the specimen, print the correct labels, and then with that, scanning automatically removes it from the work list and automatically adds the collecting clinician's name and the appropriate date and time, which can be so vital as it relates to the specimen testing process. All of this, particularly with a handheld or a mobile computer, allows the clinician to keep line of sight with those orders and with the patient. So this process undoubtedly can reduce errors and enable our clinicians to spend more time directly at the patient's bedside. Some of that increasing bettering the patient experiences, increasing the patient's trust in the process. Now, Sherry, I know you've talked about it a bit here. Would you share with us some of your experience in the implementation of bedside print and its effects in your clinical environment?
Absolutely. Thanks, Ricky. It's really been exciting. When I first came to Banner almost 3 years ago now, one of the, as I looked at kind of our landscape and looked at our areas of opportunity, one of our highest areas from a nursing error perspective was around specimen labeling errors. So our chief nursing officers were, of course, very keen to come up with some new process or technology. And as I worked with our EHR vendor and Zebra, I was able to secure funding last year in order to go live at all of our 28 hospitals and soon to be 29 as we open a new hospital in November. And so it was what's really important, and actually at our new hospital in the south east Valley, will also go live with the smartphone technology on top of the portable. So Ricky walked through kind of that high level workflow. Prior to that, it was very cumbersome. The nurses would have to grab their labels at the nurse's station. Many times they could be intertwined with other patient labels, or as she had said, sometimes there was batch labeling they were doing, meaning, okay, let me print out, I know I have to do these labs throughout the day. I'm going to print them all out in the morning and then, use them as I need to. Well, that's not the best process. We want them to do that prior to, but that could be a step that slows them down. So they would have to go get their lab labels. They would then bring them into the patient room along with their supplies, have to write on them. Many times that could get smudged or lab couldn't read it, so they would be sent back. So I looked at her data as we rolled out at one of our hospitals, one of the first ones that went live with now we don't have the phones, but what we did give them was they have the scanners on either in the room with the computer on or a computer on wheel. They would grab the portable computer, bring that into their room, and go through the process. Where we this year, and now that we're almost 8 months into it, we've only had one incident in all of 2020 related to a misidentification, down significantly. Now, I'm not saying there aren't still some issues that have happened as I look at the errors. So if there's not a label placed on a lab specimen, or if more than one patient labels are put in a bag. We put them in kind of Ziploc baggies before we send them down, for those who aren't aware that there are some other ones, but when it comes to the misidentification, that has gone down to almost zero. Lab also loves this new process because checking in the lab before was a manual process. So when that lab came to them, they then had to enter it in their system that they've received the lab. And that meant finding the nurse or the phlebotomist who had drawn it, entering the time. Now all they have to do is scan that. So we really looked at a large benefits around that. We've seen, of course, the enhanced safety and accuracy now of that specimen collection because it's closed loop from that positive patient identification. Productivity, it's because we've decreased the specimen redraws. We really looked at what was that cost as I was getting funding. The patient satisfaction. Think about if you're that patient, as I said, having to get that redraw when you just came and maybe I'm not easy at getting blood out of. It also reduced the need for label reprinting that was happening at the bedside of those hours earlier, and then I'd go to find them and half of my labels are gone. So there's a cost that was also associated from the retesting, retreatment, provides our caregivers with an efficient means for accurately labeling them. Now, the piece I would say that when we first rolled this out, in all areas, even from our peri-op in the OR, post out of the OR, ED, critical care, acute care, our ED area, when we were looking at how many portable lab printers do we need, we did find that we needed to increase that number by a couple more because while lab did a lot of the draws, if there was a need for the nurse to do it and they didn't have one available, then that would, that could lead to delays in care. Thank you for that, Vicki.
Those are great examples, and congratulations on such success with those adoption. And Dana, you were going to jump in. I'll hand it to you.
No, I was just thanking very much for providing that example and the adoption that occurred and the reduction that you've been able to achieve, which is just phenomenal. So the patient experience has been increased, right, and enhanced. Patient safety has increased as well, and it sounds like the nursing staff and the phlebotomists have been able to really be able to adopt this type of technology. So thank you very much for Ricky for being on the call, this webinar, and thank you very much, Sherry, for being able to share just some great examples and implementation at Banner Health and how successful it was. And from a huge thank you to everyone for participating with this HIMSS webinar. From here, we're going to move to Q&A. Bridget, if you could please lead out on the questions.
All right, thanks so much. So yeah, I want to first remind the audience you can continue to send in your questions using the Ask a Question panel on your screen. But we do have a couple here. So our first one is for Sherry. Did you experience any roadblocks in adoption to point-of-care printing? And if so, do you have any recommendations for overcoming them?
Yep, that is a great question. And really what I start off with is funding, right? Because if you can't get the funding for your project, and there are a lot of competing technology projects, but knowing actually the director over our lab partnered with me as we went to finance. Of course, our CNOs, our clinical leaders were on board. So really what I would recommend is you have to show your own data and outcomes of why the positive patient ID and point-of-care printing is key to decreasing errors and improving our patient experience. So when I was able to bring that to our financial leaders, showing them around, having the labs redrawn and showing them the outcomes for that, they were totally on board. So that's what I would say is the first roadblock, is securing your funding, because what we're not the best at as we roll out technology is really coming with pre and post data. And it was key for myself to bring forward to that, to show our leadership team, and especially our financial leaders who are trying to, help get the funding that we need in order to move forward. So as I presented that was a big one. So use that data and evidence to drive where to invest in your technology. And, as you can imagine, they didn't want that happening to their loved ones. I mentioned a bit about how many printers do you need. So we took a bit of an educated guess and, asked Zebra some of their thoughts around that and what they had seen from others, but also to be flexible, right? So we've done a lot of used a lot of agile methodology at Banner over the last couple of years. So we try to say, fail fast, fix fast. So if there's an opportunity, and there was in the ED, now it's not just if they're saying we need more. So we would do observations and also look at workflow to ensure that they did need more lab label printers. And so we did get those. I would say another big piece on any of these is around change management, right? So it's a new process. While many times we think, of course, everyone's going to embrace this, sometimes it may feel like there's extra steps. So as we really lay out, we get input, right? There are clinicians, our nurses, our phlebotomists, because phlebotomy also went live with this at the same time. If this was not, even though phlebotomy didn't have the errors, we really needed one process for lab to follow, especially as they check them in. So really help them design the new process. We had to educate the why and then ensure leadership was on board, and then show that data after we're live, our staff following the process, and if not, review the why and assist those clinicians to get through the barriers, and then if needed, have leadership follow up on that. Thank you.
All right, awesome, thank you. Our next question here I'm going to hand to Daniel, and then Ricky, if you want to jump in afterwards. Have you seen any examples of real-time location services for patient ID?
That's a great question. Yes, what we're starting to see is, there's varying degrees of adoption. Sherry just brought up a really great examples of moving from not having at point of care labeling to being able to implement point of care labeling, which significantly increases patient safety, as well as increases clearly, the phlebotomist to be able to accurately do blood draws and get the accurate specimens down to the lab. So when it comes to real-time location services, if you're unaware of what that means, basically what it means is utilizing a technology like BLE or RFID that transmits a signal, and what that signal does is it is able to interact with an electronic health record, as an example, and indicate where that sample is, or that specimen is, or potentially even where the patient is. So one example I'll just provide really quickly is a very large health system from the Midwest. They were doing very similar to what you're talking about, Sherry. You know, how can we improve the patient experience, have increased positive patient identification, and remove human error? And so what they've done is they've looked at their entire print environment and they've utilized BLE technology to insert prior to these wristband media being produced. So there's like a BLE beacon that's inserted in the media, and so when that is actually printed, that now encodes on that media. This is the patient. This is the patient date of birth. Here is their patient identification number. So, like, for example, their medical record number and any other information. And the benefit to that is if the barcode is smeared, let's say, or the QR code, the actual BLE beacon contains that information when you scan at the point of care, like Sherry's talking about. So they are just in the pilot phase of that right now. But what they're hoping to accomplish is be able to roll this out enterprise-wide. They get to reduce the amount of footprint of printers, having printers, you know, in all of these different settings, but more importantly, improve the patient safety to provide point-of-care labeling with really an automated technology that even removes human error more so. So that's one example that I've seen this being utilized. Ricky, can you share of another example potentially?
Sure. There are quite a few. One other one that I will say is looked to frequently is as it relates to NICU patient identification. And as we know, our NICU patients can be very sensitive to touch. And with that, and as we've shared throughout this, patient safety and patient satisfaction is top of mind for our clinicians. And so the simple unswaddling to get to a wristband for a neonatal patient can be enough cause for pause for a nurse to maybe create a workaround. And I've actually seen RFID technology in wristbands be used so that a NICU patient remain in an isolate, undisturbed, and an actual simple wanding of the isolate would act as that scan of the barcode for any type of medication administration or specimen collection process for patient identification.
All right, perfect. Thank you, both of you. Now we have a little bit of a longer question here. So this viewer says, we did a similar thing in 2009, but Wi-Fi was a problem. Now we are switching to TC51s for communication, specimen collection, and medication administration. And again, Wi-Fi is an issue. Do you have any tips and tricks to having the Wi-Fi accessed and updated so that your projects are successful?
So I can answer part of that. I don't know,
sure.
Daniel or Ricky, did you want to?
Well, I can answer part of it. If you want to lead, I can follow whichever you'd like.
Sure. I will say what we've done, and we've worked, from a nursing informatics piece and rolling out the technology. We're very closely with our IT partners and ensuring that, having the testing done. And then, because many times we hear, oh no, our Wi-Fi is great, but then when you go out and talk to the clinicians, right, you get a different story. So we also talk to them to say, are we seeing anything dropped? And we didn't have to, where we're currently live, we didn't have to make any changes. Now at our new hospital, it's opening in 2019, actually November 2nd. We're going to go live with the TC52s, and we've done our Wi-Fi where they've gone through to check it so our vendor, somebody asked me who our EHR, I see that on there, EHR vendor is that's Cerner, even for the labeling. So Cerner, I I think, has worked very closely with Zebra to ensure that the specs that we have we aren't going to have those problems. Because to your point, the person that asked this question, those are the number one issues of why it fails. So Ricky, I'll let you continue.
Great answer, Sherry. Couldn't agree more. So critical first step is certainly that collaboration and implementation in-house. So partnerships between nursing informatics, clinical leadership, and specifically IT, so that there's transparency between current environment and future. And then very importantly, partnership with your vendors. Your vendors are well experienced in implementation in many accounts, and lean into them for support and guidance through that process. Thanks, Bridget. And thank you for the question to whom submitted it.
Yeah, awesome. So this person says they may have missed, but what EMR system was used with the example for AP labeling?
Yeah, and I did answer that with my last one. This is Sherry. So we do use Cerner. And also that's with our specimen collection piece too.
Okay, perfect. And then I'm going to fit in one more question here before we wrap up. This person says, we have an issue with documentation being placed, including admission orders, on the wrong accounts. Is there a recommendation for assisting the clinician with the correct visit number to use?
So this is Sherry. I'll jump in from an overall perspective of what I've seen. Or Daniel, did you want to say something?
No, I think we're going to probably answer in the same manner. So go ahead, Sherry.
Okay.
Yep.
Well, I would say it's quite dependent in many ways on your electronic health record. You know, I have seen other technologies utilized from a kind of an RFID and walking in that room and being able to bring up, you know, the electronic health record along with that patient that's in the room. But it's, you know, unfortunately, I haven't seen, and maybe it's you're seeing the physicians usually are more of an issue. But for those that are admitted, their name should be there listed in the census, and it shouldn't be the wrong visit number. But I do understand that's happened in the past. So I'll let you complete it, Daniel, if you have anything else to add. And I know we're getting towards the end of our time.
Yeah, we certainly are. Yeah, I think the biggest thing is working with HIM to ensure that, you know, you're quickly rectifying any medical record numbers that might be duplicate. You see that quite often still, right, Sherry, where unfortunately, you know, you'll have a patient that, this happens in many states, but we see this in Arizona, of fraud, right, insurance fraud, and that sometimes occurs where the medical record number is not associated correctly with the right account. So yeah, I've seen that really great practice is working directly with HIM and quickly turning around, rectifying those problems so that it is associated with the correct account number.
All right, awesome. Thank you, everybody. So, yep, we're right at the end of the hour, but I do want to thank Sherry and Ricky and Daniel for a wonderful presentation today. For more information about HP's Healthcare Edition solutions, feel free to visit the link that is on the slide right now. Just a couple other reminders as well. There will be a survey that will pop up on your screen at the end of today's event, so please take that and share your thoughts with us. We would really appreciate it. And as a final reminder, today's session will be available for 1 year through the HIMSS Learning Center. Thanks, everybody, and have a great day.